So good morning. As we wait for some more people to join in this early morning live at 6 session, let me just tell you that we've been having this live session for last about a month and a half daily. And once this session is over, these videos are reposted on our YouTube profile. And if you want to go back and refer to them, because there is detailed description in these videos about the topics that are suggested by my subscribers, and then I give a talk in the morning, live session, early in the morning, because that's the time I'm fresh, because then the work starts at 7:30, and then things get very busy, and by the evening, it's quite tiring to do a live session. So now that we have about, say, 15 or 18 people, 15 people who have joined in. So let's talk about diffuse pattern alopecia. So diffuse pattern alopecia is a subset of androgenic alopecia, a more severe form of androgenic alopecia, and is characterized by uniform thinning across the scalp, but predominantly affecting the vertex and the mid-scalp regions. While the precise data on diffuse pattern alopecia is limited, androgenic alopecia as a whole affects up to 50% of males and females as well, with prevalence increasing with age. Though the prevalence increases with age, but the earlier the androgenic alopecia appears, the more severe it gets down the road, and the more severe it is to treat in the long term. Because more often than not, androgenic alopecia appearing early has a higher chance of having the component of diffuse unpatterned alopecia or diffuse pattern alopecia. In women, the incidence of female pattern hair loss, which we call as FPHL, includes diffuse thinning patterns as well. And this is notably higher in ladies who are post-menopausal, and affects up to 75% of women, which is a very large number, women above 65 years of age. The prime treatment of this malady, of this issue, is Finasteride, a DHT blocker, Finasteride, a 5-alpha reductase type 2 inhibitor, is commonly employed in the treatment of androgenic alopecia and is the mainstay of treatment of diffuse unpatterned alopecia and diffuse pattern alopecia. Before these patients can be considered for a hair transplant, which is always not a possibility, because in these cases, the donor area is also compromised as much as the place where you're planning to put the grafts. And it is very less likely that in about 30 to 40% cases that with treatment with Finasteride DHT blocker, you might get the patient's hair back over the head, or you might stabilize the progression of baldness, or thirdly, you might improve the robustness of the scalp donor, make it resilient enough to withstand the process of relocation transplantation. So Finasteride is the mainstay of the treatment. It's a 5-alpha reductase inhibitor and is employed in the treatment of diffuse pattern alopecia, diffuse unpatterned alopecia very routinely. And clinical studies have demonstrated that Finasteride can halt hair loss progression within 1 to 4 months, and stabilizes it completely within 4 to 6 months after having started Finasteride, with noticeable regrowth typically observed at 6 months, but may also take 9 months to 1 year at times. Long-term studies, including a 10-year evaluation in Japanese men, has shown sustained efficacy and safety of Finasteride 1 milligram per day, with significant improvements in hair growth and stabilization of hair loss. So it is important to note that while finasteride is FDA approved for male pattern baldness for androgenic alopecia, its use in women is off-label and generally reserved for postmenopausal women because of its potential teratogenic capability effect. In such cases, there are alternative treatments like spironolactone, which is an anti-androgen, or topical minoxidil, which may be considered, though they may be not as useful, not as effective, and not having as good a safety profile as finasteride. For finasteride is an FDA-approved medication, and along with minoxidil, and these form the mainstay of treatment of androgenic alopecia, and especially in cases of diffuse pattern alopecia. Another thing I want to drive home about diffuse pattern alopecia is that if the patient is contemplating a hair transplant with a condition diffuse pattern alopecia, he has to be counseled properly and he has to be religiously committed to long-term use of finasteride, because the moment he stops finasteride, within 30 days, 45 days, if the results are going to peter out, to thin out, even vanish, because these grafts which have been taken from the donor area and moved to the bald area are dependent on finasteride. If you stop finasteride, they will go back to their original condition, and therefore there was no point in taking up these patients for a hair transplant. So this information, this counseling is very important to drive home the point to the patients that if you want to start a journey of surgical hair restoration in your condition of diffuse pattern alopecia, it is very important to give it a thought, to take some time, do your research, and then once you're committed to taking finasteride in the long term, or you can also take a trial dose of finasteride for 1 month and see how your body behaves with the drug, and then make an informed decision of committing yourself to finasteride in the long term. If you're 25 years of age, if you're 27 years of age, you are definitely going to need finasteride for the long term. And with the long term, I mean till about 45 years of age, when your baldness will stabilize. And after that, you can decrease the dosage, taper it off, do not go to cold turkey. So if a person is not fit for finasteride and he has diffuse pattern alopecia, he has diffuse unpatterned alopecia, what does that person do? Well, there are other treatments available, though not as effective, not as long-lasting as finasteride is in the treatment of diffuse pattern alopecia and diffuse unpatterned alopecia. But the thing is, when you start these treatments as an alternative to finasteride, you have to keep it in your mind that when you start these treatments, since your donor area is not going to stabilize, is not going to become robust, your baldness is not going to stabilize, it's going to continue to make matters worse for you. If you are not on finasteride, please take it out of your mind that you are a candidate for a hair transplant surgery, surgical hair restoration, or ever will be. So these other treatments which will also create some semblance of improvement, but not prepare you for a hair transplant, can be topical minoxidil, 2% or 5% minoxidil, but please do not use 10% minoxidil. It causes severe headaches, and I have had several patients feeling dizzy in the workplace, and it's a big problem. So 2% and 5% minoxidil. 5% minoxidil for women is off-label. It's not recommended by FDA for use in women, but 2% is. But a lot of women are using 5% minoxidil if their body tolerates it well. So topical minoxidil is an FDA-approved treatment for both men and women. And minoxidil promotes hair growth by prolonging its anagen phase of the growth cycle. And clinical improvements are typically observed after 6 to 12 months of consistent usage. And then we come on to low-level laser therapy. Though there is no scientific basis, but people have seen improvement in growth results. And when you have a condition like diffuse pattern alopecia, and you do not have the commitment to take definitive treatment with oral finasteride for the long term, well, then you only have these options left to try and see if they suit you. So low-level laser therapy, devices such as laser combs and laser helmets have been shown to stimulate hair growth in androgenic alopecia patients. Studies suggest that LLLT can be as effective as minoxidil, but not as effective as finasteride, particularly when used in combination therapies. So we will not discuss that further much, because we are dealing with only diffuse pattern alopecia candidates who are not willing to take definitive treatment. So let's not go into the controversy of low-level laser therapy used in combination therapies. So, and then we have platelet-rich plasma therapy. I do not prescribe this treatment for reasons that it's not very, very effective in androgenic alopecia because it's not a DHT blocker. But in diffuse pattern alopecia, when we are not taking definitive treatment, you can try platelet-rich plasma therapy. It will give you momentary regrowth. It will give you momentary strengthening of your follicles. And it involves, PRP involves injecting concentrated platelets from the patient's own blood into the scalp, and it stimulates hair growth by stimulating the stem cells. And systematic reviews have indicated that PRP can improve hair density and thickness in androgenic alopecia patients. But that is another talk for another day. As far as hair transplantation is concerned, for patients with a stable donor, a donor which has been rendered robust, thick enough, good caliber donor hair after the usage of tablet finasteride, and there is adequate hair density, surgical options like FUT and FUE can provide permanent solutions. But as I told you, once your hair are dependent on finasteride, you will have to take it in the long term up to, say, about 45 years of age. Hair transplant in the ideal condition in diffuse pattern alopecia is particularly effective where you want long-term natural results. But these patients are not, every person with diffuse pattern alopecia is not a candidate for a hair transplant surgery. And then there are certain emerging treatments, adjunctive therapies, such as microneedling, such as use of topical anti-androgens. The new one, topilutamide, and these are being explored for their potential benefits in androgenic alopecia management. However, more robust clinical trials are needed to establish the efficacy and safety profiles. Treatments come and go. Every 2 years, there's a new treatment touted, and then within 2 years, you never hear about it again. That is the tragic condition of hair loss treatment research today. The only treatments that we have today for the past over 3-4 decades now are the 2 FDA-approved medications, finasteride oral and topical minoxidil. So it is very unfortunate that not much research is going into hair loss treatment, and we are still at the same place where we were some decades back. So then we come on to these questions. Question number one, which is for the last 1 month, I've been getting questions from patients about diffuse pattern alopecia, and you can see diffuse pattern alopecia is so very common, and increasingly it is becoming more and more common because of our lifestyle, because of our habits. Diffuse pattern alopecia, when I started my practice about 20 years back, was not as common as it is today, and every year more and more cases are getting are unfit for hair transplant because the thinning in the donor area is unremitting. It is relentless. Diffuse pattern alopecia patients and diffuse unpatterned alopecia patients are increasing day by day every passing year. And it is becoming so very common, an epidemic actually of diffuse thinning, which does not have much treatment, which we can offer as hair loss doctors and hair transplant surgeons. So coming to the first question, how can clinicians enhance the diagnostic accuracy to effectively differentiate between DPA and DUPA, ensuring appropriate treatment pathways? Well, differentiating between DPA and DUPA is pivotal. Only after you have differentiated it can you make a plan for the treatment? Can you set in place protocols for management of these two conditions? And this differentiation directly influences treatment decisions. DPA, that is diffuse pattern alopecia, typically presents with diffuse thinning confined to the top of the scalp, preserving the occipital donor area, making patients suitable candidates for hair transplantation, but after management with medication. In contrast, DUPA, diffuse unpatterned alopecia, involves uniform thinning across the entire scalp, including the sides, back, and rendering the donor area unstable and unsuitable for transplantation. Diagnostic tools such as trichoscopy can reveal follicular miniaturization patterns, but it can also easily be done clinically. Scalp biopsies are occasionally required in ambiguous cases to assess the follicular health and to rule out scarring alopecias wherever there is a doubt. And recognizing these two patterns, DPA and DUPA, is crucial to ensure patients receive appropriate and effective treatments. Then we come on to the question number 2. What are the long-term outcomes of finasteride therapy in diffuse pattern alopecia patients, and how do these outcomes compare to those in patients with other forms of androgenic alopecia, the regular forms of male pattern baldness? Well, finasteride is an 5-alpha reductase inhibitor and has demonstrated significant efficacy in treating androgenic alopecia, including DPA. And long-term studies have shown that finasteride can halt hair loss progression and promote regrowth, particularly in the vertex region, the crown area. Notably, the vertex type 5 male pattern baldness exhibits the most rapid and sustained response, with 89.7% of patients showing improvement. And these findings underscore the importance of early intervention. A stitch in time saves 9, and this maximizes therapeutic outcomes. And coming to the third question, in cases where traditional treatments like finasteride and minoxidil are ineffective, what emerging therapies show promise for managing DPA and DUPA? See, though these are the keystones of management of various forms of androgenic alopecia, other treatments can be tried, but I actually really doubt that they will be beneficial if the definitive treatment has failed. But these treatments, as I told you earlier, are low-level laser therapy, platelet-rich plasma, microneedling, and topical anti-androgens. And a recent thing which is being explored is topical melatonin. Topical melatonin has antioxidant properties and may counteract oxidative stress in hair follicles because of lifestyle changes, and potentially promotes hair growth. So this can also be tried in patients who have diffuse pattern alopecia. But these therapies are merely adjuncts or alternative therapies, not as beneficial as the keystone of treatment with DHT blockers. But they can be used in cases where traditional treatments are contraindicated or are ineffective. And this brings us to the fourth question. Given the diffuse nature of hair loss in DPA and DUPA, what criteria should be used to determine the suitability of patients for hair transplant procedures? Well, hair transplantation, your suitability or candidacy for a hair transplantation hinges on the stability and density of your donor area. There are no two ways about it. There's no doubt. In diffuse pattern alopecia, the donor area is typically preserved but poor, so there is still hope for surgical hair restoration. Conversely, in DUPA, that is diffuse unpatterned alopecia, the donor area is adversely affected and has many times reached a point of no return. Also, there is overall thinning on the head, and there is no clear bald area, or perhaps there is for only the hairline and the temple points. Hair transplant, therefore, is not meant for DUPA unless it is just the hairline that is to be corrected. But judicious planning is required, since procedures can lead to poor graft survival and suboptimal outcomes. Therefore, assessing the donor area stability is of paramount importance. And this needs to be assessed through clinical examination, diagnostic tools, taking good history taking, to avoid putting the cart before the horse in planning surgical hair restoration. And the last question for the day, and then we end the talk, is how can practitioners balance the desire for aesthetic improvement with ethical considerations, particularly in recommending invasive procedures for conditions like DUPA, where donor area stability is compromised. Basically, to put it simply, when the patient is adamant on getting a hair transplant done, what is the approach of the doctor? Well, ethical practice mandates that treatments are recommended based on clinical indications rather than the patient desire or the patient's forcefulness or the amount of money that the patient is giving you. In cases like DUPA, where the donor area is compromised, recommending hair transplantation would be a very unethical decision on the part of the doctor due to the high risk of poor outcomes. Practitioners should therefore prioritize patient education, discuss the limitations, discuss the potential risks of procedures in DUPA, and explore alternative treatments rather than straight away go in for a hair transplant surgery. This approach ensures that not all that glitters is gold, and patients are guided towards safe and effective management strategies, holding the interest of the patient prime, not the revenue generation of the clinic. So that is the end of the talk. If you have any questions, any doubts in your mind, please let me know. I will not be taking any questions now, but if you have any questions, please put the questions in this video once it is uploaded on YouTube. For those who haven't subscribed but are watching, please do me a favor, subscribe to the channel. I'll be very grateful because your engagement keeps the channel going and the commitment going. So have a nice day and may God bless you.